Great, welcome.
Welcome, everyone.
Welcome, everyone. Welcome, welcome. Glad to see people coming in. If you would like, as we have done before, go ahead and send your greetings in the chat. Just your name and where you're coming from, just so we know who is here among us. Hello, hello. We see some folks joining by video. Good to have you. All right, just give us another 2-3 minutes or so, and then we'll get started.
Great. And in case you're wondering how you got here, you were at the operations and maintenance session on Washington Healthcare Facilities. Hope you intended to join us. And please feel free to introduce yourselves to each other in the chat box. Joseph, glad you could make it. Great to see you on a Wednesday morning.
Hello, great. We have some folks. Hello, Natasha, coming from Malawi. Hi, Lori, New York City, my home state, New York. Oh, we have some more people from Ethiopia. Chisomo from Malawi, LA. Nice to have you join us. Hi, Peter.
Hello. What time is it in LA? Good morning.
It's early.
It's 5:30 in the morning.
Whew.
Sorry, Peter.
God bless you. Glad to have
That's
you.
okay. I've got my coffee.
That's right. Oh, we have some folks from the UK and Philippines and Venezuela. Welcome, welcome, Kenya.
We'll get started in just a second here. Haley, can you just double check that Spanish is interpreting all good? Or sorry, French is interpreting all good.
That's actually a great comment, Lindsay. Just want to make sure those joining us, please go ahead and select your preferred language. We do have interpreters working with us. We even ask those who are listening in English to please go ahead and select English.
Good morning. Yeah, we may have some Spanish commentary on here today, so just beware if you're not bilingual. Do we want to go ahead and get started, Joanne? I'll get the slides up for you.
Sure, please go ahead.
1 second. All right, there you go.
All righty, so again, good morning, good afternoon, good evening to everyone. I want to welcome you to the Washington Healthcare Facilities Community of Practice Initiative. Today's discussion is going to focus on the core elements of operations and maintenance for Washington Healthcare Facilities, and we're going to have a discussion on sustainability. We're so very glad that you can join us today. I want to introduce myself and our team. My name is Joanne McGriff, Assistant Professor within the Department of Global Health, here within the Rollins School of Public Health at Emory University, and I'm also a core faculty within the Center for Global Safe WASH at Emory. I have with me, many of you have already been hearing from Lindsay Denny, who's also with the Rollins School of Public Health, and Haley Elling from World Vision. We also have a fantastic team of interpreters who will assist Spanish and French-speaking participants. So in fact, like I just said a few moments ago, if you haven't already, please go ahead and choose your language of choice in the bottom toolbar. And we're asking participants actually who are listening in English to also make sure you choose English. We are really looking forward to a great set of presentations today and discussions, especially because you get to meet members and associates of our Community of Practice Steering Committee. These are the individuals who advise us, provide technical expertise, and other resources to help make this community of practice relevant, informative, and responsive to the needs of the Washington Healthcare Facility community. So today's session really has been conceived by and will be presented by some of the steering committee members representing organizations such as Save the Children, UNICEF, Engineers Without Borders, Terra de Om, and AMREF Health. So we're just going to go ahead and launch in and get started. Next slide. As we always do, I want to begin with a short reminder of what this community of practice is really about. We are an action-oriented learning platform that brings together the WASH and health communities to focus on policy, evidence, and practice in WASH and healthcare facilities. Our goal is to connect the expertise and experience of our partners and colleagues to the members of the WASH and health community who have expressed interest in taking action in WASH and healthcare facilities. We've created this platform as well as our newsletter, our webpage to share resources. And each time we meet, we want to walk away with some steps that we all can take to advance the improvement of WASH and healthcare facilities. So we welcome everyone to participate in these webinars, whether you are a seasoned expert in WASH and healthcare facilities, or someone for whom this topic is brand new. This is a space for you. So next slide. I also want to remind everyone of the guiding principles of this COP, this community of practice, so that you know where we're coming from in these webinars and when you see our newsletter. First, WASH is a fundamental prerequisite for quality care within a healthcare facility. And we believe very strongly that there cannot be effective infection prevention and control, better known as IPC, without adequate WASH. That is a full stop belief that we have, and we think the two must always be working together. We also believe that the issues around WASH and healthcare facilities are solvable, but it will take multiple systems, sectors, stakeholders to work together in order for us to see sustainable improvements. And then, as I mentioned before, the community of practice is open to all who seek to learn and share about WASH and healthcare facilities. We respect the diversity of perspectives and hope that whether it's in the presentations or in our discussions, that we will hear the voices of the community and be able to not only sort of log your ideas, but also respond to requests that you have for future webinars. Next slide. Each time we meet, we try to make sure that we are celebrating success. We know the work of WASH and healthcare facilities is difficult. It's a long arc, if you will, but there are times where we have really great things happening. So for this webinar, we're going to be highlighting the work of the Vatican in WASH and healthcare facilities. The Dicastery for Promoting Integral Human Development has organized an assessment of 150 healthcare facilities in 23 countries where they have essentially pulled together both Catholic and non-Catholic partners to support improvements. And so we have a list of partners, as you see below here, that really have worked together to identify which facilities that they're going to address gaps. And again, I think it's going to be that this may expand beyond the 150 that they're working with now. So this is really good news to hear and to see different partners working together on this. Next slide. Another thing we always do is make sure that we put in front of you some of the latest news as it relates to WASH and healthcare facilities. If you are not already reading our newsletter, we have today, at least, the announcement around the new publication estimating the cost of achieving basic WASH and waste management services in public health facilities in the 46 UN designated least developed countries. And this was a modeling study, again, just released. And really the big news here is that it's an estimated 6.5 to 9.6 billion dollars that will be needed between 2021 and 2030 to achieve full coverage of basic WASH in least developed countries. So again, we'd had some estimates that had come out before. Those have shifted, and now we've come to this particular number. So if this is of interest to you, please make sure we have a resource list that we will be releasing after this session to check out this paper and some of the results and findings. Next slide. And then lastly, we just wanted to make you aware that WASH Fit's second edition will be published next week. So those of you who are familiar with WASH Fit, this is an assessment tool that has been designed, promoted, and really has been expanded quite a bit by WHO. We want to also say, and I've been told to make sure I'm clear, that this new updated version does not mean that it's new. Right? So if you've been using the WASH Fit from the first edition, if you will, or the first version, you are fine. There is nothing that is wrong with that first tool, but this one has some updates, right? So some new things that include considerations for new settings like tertiary hospitals. There's some consideration for cross-cutting issues like gender, equity, and climate, and greater emphasis on prevention. So please go ahead and check out this second version and see what are these additional elements. And please pay attention that on April 26th, there's going to be a launch event of this tool where different members of WHO and stakeholders will have an opportunity to share what these updates are with the Washington Healthcare Facility or WASH community at large. And this would just be a great time for you to tune in and perhaps ask questions and receive some further guidance on this. And so with that, I will go ahead and go to the next slide, pass it on to one of our first steering committee members. This is Jason Lopez from Save the Children, who's going to take us through an overview of operations and maintenance for Washington Healthcare Facilities. So over to you, Jason.
Good morning, everybody. Bonjour, buenos dias. I'm here to give you a quick overview of operation and maintenance in Washington Healthcare Facilities. So what is operations and maintenance? So formal definition, routine or periodic task required to keep a process or system functioning according to performance requirements and to prevent delays, repairs, or downtime. This includes regular maintenance, repairs, checks, adjustments, as well as related financial, human, and institutional resources. So what are the tasks and activities needed to keep a system going, such as a healthcare facility? Next slide. So we all practice operations and maintenance every day, right? So we brush our teeth to maintain our teeth. We wash our hands at appropriate times to maintain our health. We replace the buttons and resole our shoes to make sure our clothes are operating correctly and well maintained. We eat nutritious food and exercise for our bodies, and we attend webinars and learn to use smart art, like in this slide, for our minds. Next slide. In the case of operations and maintenance in healthcare facilities, some examples are regular testing and monitoring for water quality. Hand washing stations are available and functional for hygiene. Emptying and disposing of fecal sludge from a septic tank. So that's to ensure proper sanitation. To ensure continuous operations and maintenance is required for cleaning and maintenance of incinerators for waste management. And for cleaning, you need to ensure that the PPE is available for cleaning and waste management. Next slide, please. Okay, so why the emphasis on operations and maintenance? Why are we having this discussion here? So without operation and maintenance, all of our infrastructure would eventually stop working. And on top of that, badly maintained wash facilities are often can often cause even a bigger health risk, right? So if you have, let's say, large amounts of standing water, you pose a risk for malaria, for example. For operations maintenance is common cited as the leading factor for breakdowns of wash services, including in healthcare facilities. There was an assessment in East and Southern Africa of wash and healthcare facilities, and it found that out of all the things they assessed, they found that operation maintenance had the weakest score. 13 out of the 19 countries they assessed indicated that there was no national operations and maintenance plan for healthcare facilities, and the study cited limited financing, limited human capacity, inadequate policies, and lack of coordination as the reasons for it. Operations and maintenance is also recognized as a cost-effective investment. It's usually cheaper to maintain your car, for example, than to buy a new one. However, new construction is often prioritized over operations and maintenance. People often don't see operations and maintenance, but that's if you have a bridge and you repair it, nobody sees that. But if the bridge, falls in disrepair and you have to build a new one, people see that, people notice. Next slide, please. So operations and maintenance by facility size. So just to give you an idea, so in smaller primary and secondary facilities, the operation and maintenance needs can be very basic, so it's usually around wash infrastructure. However, they often have less resources. They often don't have dedicated operations and maintenance staff. They're often financed through local government or civil society or the communities themselves. For larger tertiary facilities, they have more complex operation maintenance needs, such as inpatient services or keeping the ventilation in the operating room operating, processing of surgical equipment, and because of their larger size, they often have more. They do often have dedicated staff, such as an environmental health personnel. Sometimes they're called a hygienist, and they have financed often through the regional and national government. Next slide, please. So there are various stakeholders involved in operation and maintenance. So you have your ministries of health. That's at all levels. They provide funding, technical expertise, training, maintenance, monitoring, and oversight. Municipalities are often involved, also often providing funding, usually for primary and secondary care. They often have technical expertise or engineers at the municipality, and often conduct a routine maintenance. Communities also get involved, not only as patients but also as overseers. They usually part of community committees. They often provide funding and labor as well. The private sector is often a key actor. So if you want to do construction, construction, that's often through a contractor. Certain repairs that need to be done by a specialized contractor. Maintenance, so cleaning is often contracted out as well, and same thing for operations, often waste management, or even inspecting equipment. So if you want to have a professional come and inspect a piece of equipment. And then finally, a civil society, which often provides funding, technical expertise, and advocacy. Next slide, please. So through the health system, nationally, the Ministry of Health usually allocate budgets for healthcare facilities and operations maintenance and provide oversight. Subnationally, they usually request monies, but also often have budgets to allocate. They provide staff training, oversight, and they may have technical experts for repairs. And at the facility level, they usually request monies from national or subnational, provide direct training and service training to their staff, and conduct a routine and preventative maintenance. So not specialized maintenance usually. Next slide, please. So financing of operations and maintenance. So the financing is often overlooked in budget allocation. In reality, when you design a project, you should even budget for operations and maintenance at the time. So if you're constructing a new healthcare facility, this should be considered throughout the lifetime of the facility. Cost sharing of operations maintenance and the mechanisms by which money is allocated is an important discussion among WASH and health sector partners. Keep in mind that each subnational team or sector has their own priorities. The cardiologist might be looking out for the priorities of the cardiologists, and the lab might be looking out for the priorities of the labs. So funding is usually limited, and there are a lot of people with their own priorities. So one example of a mechanism to support long-term operations maintenance through existing health system monitoring systems is results-based financing, which has been used in countries like Uganda to strengthen WASH and healthcare facilities and pay for ongoing costs. Next slide, please. So this is an example of, this is the Guatemala healthcare facility management structure, right? So you have Ministry of Health, Vice Ministry, then you have your tertiary and and then secondary and primary care. They're managed accordingly. Next slide. But I just wanted to show you that the financing doesn't really match the management structure, right? So in the case of the hospitals, they're managed by the Vice Ministry, the Ministry of Health, uh, and receive funding through the Ministry of Health. However, for the primary and secondary facilities, they do get some money from the health area, which is for operation and maintenance, but then they get their infrastructure costs from the municipality. So, and even then, like, you know, there's the line between operations and maintenance and infrastructure can cannot be clear always, but also they get support from the communities themselves, civil society, even in the case of Guatemala, the Ministry of Defense. So the funding, the management structures and the funding structures don't, and the financing structures aren't necessarily aligned. Next slide. So a few key considerations. So what is required to plan and execute operations maintenance at the facility level? So we develop operations and maintenance plans with stakeholders, preventative maintenance, keeping a stock of spare parts, innovations. And when I say innovations, just keep in mind when we innovate things, it's how do we make the healthcare facility staff lives easier. Life cycle costs, which is what's the whole lifetime cost of a facility. Most infrastructure has a lifetime of 50 years old. So how do you cost that into the project from its inception? What human resources are needed to execute operation and maintenance? Well, you need people with technical skills, such as someone to be able to change a gasket, but you also need soft skills for someone to procure the gasket. Often you need outsourcing for not just a cleaning contractor, but let's say you know, you need someone to actually do a specific task for need specific skills that aren't within the facilities. And community communication and engagement. Always consider budgeting, which requires developing a budget, submitting budget requests, and advocating for budget allocation specifically for operations and maintenance. Next slide, please. Some more key considerations are need for guidance, so frameworks on operation and maintenance, policies and guidelines, and of course inclusive operations and maintenance, so consideration for all stakeholders. Monitoring, so conducting you know, monitoring of healthcare facilities, community scorecards to know what are the needs, operation and maintenance needs of the facilities. And community engagement, so getting feedback on what the priorities are of communities and patients, and raising awareness on using the systems. All right, that's my introduction to operations and maintenance. Thank you all.
Great. Thank you so much, Jason. Really great overview. So now we're going to move to the segment of the webinar where we're going to take several of these topics and just dive a little bit deeper. And so we're going to begin with our first presenter. This is Steve Crow, a country director from Engineers Without Borders, Guatemala. And he's going to cover our first theme in more depth, planning for O&M in healthcare facilities. So handing it over to you, Steve.
Great, thank you, Joanne. Yeah, can we go on to the next slide, please? So I want to start out talking a little bit about how is O&M for Washington healthcare facilities different from other contexts. I know that a lot of people come from, you know, maybe community wash or wash in schools. And so just kind of set a little bit of a base of what the differences are. In technology and infrastructure, it's usually not the determining factor. We get a lot of variation, you know, among different types of healthcare facilities, just like we do among different types of communities, sizes of communities, types of schools, sizes of schools. Healthcare facilities do have to deal with infectious disease. So that's one difference that we'll see in technology, but the sort of rest of the realm of wash, you know, water supply, you know, black water, gray water, that kind of thing, most of it is pretty similar. The main differentiating factor really is the institutional context, the stakeholders. So, you know, everything that Jason was talking about, that emphasis he really put on that, that's the main differentiating factor. And it's something that's really important to take into account when we're planning for O&M. Next slide, please. So first, planning is different for different types of facilities. We have different levels of infrastructure. A small primary facility was really going to have very basic infrastructure, might just have, a faucet for potable water and really not much else. Different levels of staffing can go from no permanent staff to, just medical staff to, a full build out of medical admin and O&M staff. The institutional context, of course, is different. And then there's public facilities, there's nonprofit or church facilities, and then there's private for-profit facilities. Those are all going to be very different. In the rest of my slides, when I use examples, I'm going to be talking about the Guatemalan system, which is what I know best. So can we go on to the next slide, please? And this is just a reminder, kind of basically what Jason was talking about. Is the Guatemalan system, the three levels that we're going to be talking about here. The primary or the community level health centers is here. These are health centers that aren't staffed permanently. There might be a building in a community. They might share a building with another, community function. And they usually get visits maybe once a week or once every 2 weeks from doctors from the municipal level health centers. So those are the secondary health centers. Those is staffed permanently, but they have more of a limited range of services they provide. They won't do surgeries, for example, but they do have permanent staff. Sometimes they do have maintenance staff. Sometimes they don't. And then the hospitals are, those tertiary level centers. Those have usually a full range of staff and a full range of services, and much more complex infrastructure and technology. Next slide, please. So when we get started with planning for O&M, the first thing, if we're coming from the perspective of a nonprofit or some sort of agency that's doing an intervention in a healthcare facility, we need to include planning from the start. Whether that's a new facility, where in that case planning is maybe a little bit simpler, or most cases, at least the work that we do here in Guatemala, most cases are repairs or upgrades. There's not a whole bunch of construction of new facilities. So they might be expansions, they might be repairs of things that aren't working, they might be putting in more modern equipment. So the first thing that we need to do is start with an analysis of how things got where they are. Why did the infrastructure fail? Was it poor quality equipment? Has the facility grown beyond the capacity of the equipment? Is it just age, wear over time? Was there some sort of barrier to maintenance? Did they lack the knowledge? Did they lack the budget? You need to ask all these questions and work with all the stakeholders to develop a plan for how to avoid repeating this, and also commitment to follow through on that plan. The Guatemalan system, as Jason pointed out, is kind of complex because the management structure is different from the financing structure. And so you need to really identify, and I think you're going to find your own complexities wherever you work. You need to really identify what are those stakeholders and involve them all in this analysis and in the planning of the O&M for the improved technology or infrastructure that we're going to leave in place. Next slide. So dive in a little bit deeper into what is O&M. O&M is operations and maintenance, and then we have two types of maintenance, really. So operations really are regularly scheduled activities that are required to keep the infrastructure running. A lot of hospitals might have their own water pump. So, turning the water pump on and off, filling up the chlorinator that disinfects the water. Something that you're going to see in really all the levels is, filling up soap, replacing paper towels, things like that. So those are basic sort of operations activities that you'll see in different levels of facilities. Next slide. So then we have the next thing we have is preventive maintenance. So this is regularly scheduled maintenance activities that help prevent unexpected failures in the future. So these, the kind of obvious example outside of wash or anything else that I think probably a lot of us are familiar with would be like changing the oil in our car. That's a preventive thing that we do on a regular schedule that keeps the car, running. With wash, this can involve testing and monitoring things like water quality, measuring voltage or other pump performance parameters, cleaning, keeping things, keeping pipes or mechanisms or tanks, filters clean, and then changing things like filter cartridges that need regular replacement. Next slide. And then finally, we have corrective maintenance. So this is what we do once a piece of equipment has failed. This doesn't necessarily mean that it's unexpected. We can, and one of the things that we need to do when we're planning is we need to understand more or less how often we can expect these things to fail. Gaskets, seals, pipes, they're all going to cause leaks. We can know more or less how often that's going to happen. Same thing with water pumps or the controls of water pumps. We know that they're going to fail. A pump maybe is going to last 10 years. And something that doesn't necessarily get considered a lot is something simple like floor tiles. It doesn't seem like wash, but really having a broken floor tiles is one of the most common things that we see that can really affect the hygiene of a facility. Those broken floor tiles really provide a place for the contamination to gather and infections to gather. Next slide, please. So how do we go about planning? So there's a set of questions that we can ask to go through the planning process. First, just identify what technology there is in the facility. Like I said, a primary facility might only be a latrine and a faucet. A tertiary facility might be 50 toilets and 40 hand washing stations and a kilometer of pipe or something like that. So be very specific about what the different things are that we're going to need to do operations and maintenance on. Then look at how often those are going to happen. Especially start with the operations and preventive maintenance, because those are going to happen on a regular schedule that you can control. So schedule those out, and then for the corrective maintenance, try to project it. So like I said, a water pump typically will expect to last 10 years. For piping, you might expect a certain amount of pipes to be replaced every year. There's a certain percentage of toilets or sinks that you would expect to have leaks in every year. So you can project those things out, identify the materials required for all those activities, and then the skills required. Are these things that are going to be in-house? In a community health center, there's not going to be any permanent staff. It might be the community members themselves that are going to go in and fix the faucet. In a secondary facility, it might be the janitor that does those things, or it might be somebody from the municipal government that comes in and helps out. And then our tertiary facility, it might be a permanent staff, or it might be somebody that's contracted out. And then all the answers to all these questions are going to feed into the staffing plan and budget, as well as the schedule and the overall plan. Next slide. So, how does the institutional context influence that? You have to ask who's going to pay for it, who's actually going to do the work, who's going to actually change the faucet, who has to authorize the work, who provides support. And the answers to these questions will be different for each type of facility. So look at all those stakeholders again and try to identify who's going to play those different roles and get them involved in that process. Next slide. And then finally, a monitoring and evaluation from the facility perspective. We need to follow up and kind of make sure that the plan is carried out, right? So, we have O&M logs. We might have specific logs for specific activities. There might be a log for water quality testing, where you actually have a table printed out with the different parameters that you're testing. And so every day that test is done, the person responsible writes down the values of the parameters on that specific log. That might be the same with things like incinerators. You need to check the fuel level and things like that. So there might be specific logs for specific things, and then other sort of more general logs for things like repairs. That just a place for people to write down what they do. Identify who's going to be responsible for identifying the problems. Is it just going to be, somebody notices that there's a leak and they tell somebody, or is there a regular inspection? That's sort of part of the preventive maintenance planning. But it's also part of the following up and the monitoring. Reports on what's done and also on the inventory. If it's a larger tertiary facility, has an inventory, you should have a log for that. And it should, if there is a maintenance department, it should include someone outside of the maintenance department as well. We don't want it to be just sort of like an internal thing that, it's a lot easier to lose control that way. So, involving people that are involved in maintenance, but also in administration, and in the places where we've seen this be more successful, they also involve medical personnel. So some of the hospitals we work at actually have a sort of committee of medical personnel that also provides that perspective on how well things are working for them. And that's been really successful. So yeah, that's it for my presentation. I'd be happy to answer any questions.
Great. Thank you so much, Steve. Really in-depth coverage and discussion of the issues as it relates to planning. We do have time for one question that we see came up for you as you were speaking in the chat. And this is from Matthias, who's asking, did you use an overall guiding framework? And in particular, did you use a specific tool for the problem analysis phase that you were discussing? Meaning how you find out how things got into the shape that they've currently in.
Yeah, that's a great question. When we were starting out planning, we did look around for some tools, and we didn't find anything that really adapted to exactly what we wanted. So basically, we went in with a bunch of open-ended questions and tried to involve everybody that we could in the discussion. So those questions that I had on my slide, and the first step is identifying the stakeholders and then taking those questions to those stakeholders and really doing that analysis with everybody.
Great, thank you so much. I know we probably have others who are still thinking about this great information that you've just shared, but just in the interest of time and because we have so many other presentations, I'm going to go ahead and pass on to Lindsay, who's going to introduce and walk us through the other theme that we're working on for today, on personnel for O&M. So over to you, Lindsay.
Great. Thank you, Joanne. Thank you all. So I just want to quickly give an introduction, and then I'm going to share a couple of videos. So when we talk about personnel, we're talking about human resources. And I thought Jason gave a really great summary at the start here, but just to reiterate, some of the issues that we're focused on here, roles and responsibilities. So who on the staff is responsible for various O&M activities? And is there a dedicated O&M staff or team? As was mentioned earlier, it really was probably going to vary based on the facility size and really what the capacity is of the staff within that. You may have nurses and doctors who are also acting as human resources for O&M, and you may have dedicated O&M staff, depending. Skill building, how are the skills to perform O&M developed? And also, as Jason mentioned, there are soft skills and hard skills, so both are valuable. Are there opportunities to develop that either at the facility or through other resources? Communication and engagement, what system is in place to communicate O&M needs and budgets, and even communication between the director and the maintenance staff. And then lastly, outsourcing, what activities might be outsourced, whether that's preventative or corrective. We've certainly worked in facilities where there's a certain limit when a certain breakdown happens that has to be outsourced to an engineer in the community, et cetera. And then the question is, where does that outsourcing come from? Is that contracting a cleaning service in the community, or do you have to source somewhere further? So I'm going to stop sharing the PowerPoint for a second, and I'm going to pull up. We have 2 videos to share with you from our colleagues in UNICEF India and the work they're doing in a healthcare facility, primary healthcare facility, Shipra. So let me go ahead and pull that up. For those of you who are watching or getting this translated, there will not be any interpretation for the videos. So please come back to the main room right now and you'll be able to hear it if you are able to, if you have any English to be able to listen in. All right, where did the video go? All right, can you see this, Joanne?
Namaste, myself Dr. Trupti
Yes.
Kajare, MO in charge of PHC Shipra. After attending a regional training of WASH, I came to my facility and I took a round, and my team did a comprehensive assessment of WASH with the help of comprehensive tool. UNICEF team and NHM team helped me a lot, and we finally got a 12 action key point to fulfill our gap. And to fulfill this 12 action point, we need a fund. We don't have any dedicated fund for the WASH. So our infection prevention control committee decided we have to use our untied fund. Untied fund we used, and some fund we are using from the Rogi Kalyan Samiti, and NHM, some amount of NHM is also given for the development of our facility, around 2 lakhs. So we finally got our funding and start work on it, and within a couple of days we got a 5-star ranking. We basically focused on the segregation of the biomedical waste and safe disposable and safe transportation within 48 hours within our facility. We also work on the water sanitation. We are decided of water tank cleaning once in a month, and we recorded very well. Then chemical testing with twice in a year, and biomedical bacteriological testing quarterly on the year. We ensure 3 times toilet cleaning and 3 times all the cleaning of all the wards like NC, PNC wards. We made a checklist of this all cleaning time and schedule. Also, by this all activities, we made an infection prevention control committee and took a meeting on the monthly basis. By these all activities, very proudly to say, after WASH, we got a 5-star ranking. We got a 3 times Kayakalp award, and we getting a prize money for this award also. And we utilize this fund also to sustain this facility in terms of quality. And very proudly to say is that after 3 times Kayakalp award, first time we got a National Quality Assurance Award. This is the first PHC in Madhya Pradesh. So thank you so much UNICEF team and NHM team for this opportunities. Thank you so much.
So I'll go ahead and play one more video here, and we'll share the story of the cleaner here who also was involved in this process. So let me go ahead and do a new share. 1 second, lots of videos going on.
मीला हुई है। मैं 2013 से अस्पताल में सहायक कर्मचारी हूँ। पहले हम झाड़ू लगाते थे और एक बाल्टी से पोछा लगाते थे, जिसके बाद में हमारी टेलिंग हुई 2018 में। तो हमने वो मोक से किलिंग करते और पोछा लगाते हम 3 बकेट से, 3 बकेट अलग अलग, सरफ का पानी, सादा पानी, हाथों का पानी। पीप किट पहले हम पहनते नहीं थे, हमारी टेलिंग हुई 2018 में। जब से हम पीप किट भी पहनने लगे, हमारा परिवार, हम, हमारे पेशेंट सब सुरक्षित हैं।
Wonderful. So I think it's great to see the experiences from our colleagues in India of the approach to personnel, working with both the director of the facility, the medical in charge at this primary health center, as well as the sanitation worker, and understanding how this training has built up their skills, noting that that was one of the key issues that has been identified as a challenge within these healthcare facilities. So I do want to allow, we've got a few minutes here, whether any of our colleagues from the India team would like to make any additional commentary. If you'd like to just unmute yourself, you can go ahead and make any reflections here.
Good evening.
Can I come in? Yeah. So we have Dr. Pankaj Shukla, who is the director of National Health Mission. So he will be telling you about what happened in Madhya Pradesh, specifically the central part of India, as far as the WASH and IPC is concerned. Continue, Dr. Pankaj Shukla.
Good evening in India and good morning in America. And I would like to share that in 2017-18, we had partnered with UNICEF India to launch WASH in Health and MRC. And this program went well with capacity building, and we had a very good tool also. And we have done capacity building at all the levels, state level, regional level, and the institutions level also. The team of UNICEF had given us brilliant support for that. And before that, we were not doing well with WASH activities. We were primitive doing that thing. And meanwhile, at that time, our Prime Minister launched a Swachh Bharat Abhiyan, that is cleanliness drive in India. And for Health Department, a Kayakalp scheme was launched, which was equivalent to WASH. All Kayakalp initiatives had 65% WASH activity in their mandate, and with the same thing, we proceeded with doing with UNICEF team and Health Department team. We had for operational and maintenance, we had a very good outsource agency for housekeeping, and the fund is also given by government. And we, for the maintenance and the other part, for that, we had provided untied fund at the rate of 1.75 lakhs for PSC and 3 lakhs for CSC and 5 to 10 lakhs for district hospital. Apart from that, for a CSC, we had provided under Swachh Sarvat scheme, that was ODF, outdoor defecation free India. We had given 10 lakhs for every CSC to improve their WASH activity. And apart from that, the untied fund and triple S 10 lakhs, we had given the traversing gap money also for improving this facility. And I would like to mention that we were struggling with lack of water supply from different sources. Now our state government has decided to give all the health facilities with the pumped chlorinated water supply to everything. And we have also, I was looking after the presentation of the different countries, we have also developed 3 times cleaning and all the modern cleaning methods and the formats, daily checklist and everything. And I'm thankful to the UNICEF team for giving me such a wonderful, and I think about 400 facilities out of 200 facilities are now Kayakalp certified. Thank you very much. That is what I wanted to.
Wonderful, wonderful, excellent. Thank you so much, Dr. Shukla. That is such a great thing to hear, how many hospitals have been certified. This is just fantastic. And we just thought this was such an important thing to actually hear voices from the field. So we really do thank you for that. I see Dr. Bhagawan, did you want to make a comment?
Yes, I just want to add Dr. Shukla's statements. I mean, as he shared, the coordination and convergence between the facility level and the district level and the state level. At all the level, nodal officers was also being appointed to monitor, and bi-monthly periodic monitoring and the Android mobile app based monitoring is also been regularized. And every facility, we are still working under leadership of our Pankaj Mathur sir and Pankaj Shukla sir. Every facility in charge themselves are doing the Android-based bi-monthly monitoring. And finally, we are preparing the dashboard and sharing with the district and the states to take actions based on the gaps identified. So this is it's a part of the plan also. So thank you very much. Pankaj Mathur sir is there. I think I would request to add anything if it's missing.
Perfect.
Nothing
Thank
to
you.
add. I think the testimony from two people from Shipra PHC were sufficient enough to let everybody know that how Madhya Pradesh, specifically in India, has been able to do wonders in healthcare facilities, specifically wash and IPC part. And as Dr. Pankaj Shukla has already mentioned, that it is maximizing the available resources plus capacity building of the medical officer in charges plus the cleaning staff, as well as you already pointed out, the close monitoring on a star-based app was, success factors, I would say. And UNICEF is really happy to be part of it. Thank you very much. Thanks a lot. Over to you, Lindsay.
Wonderful. Wonderful, wonderful. Thank you so much. And I also want to just bring attention and say very much thank you to the two women featured in the videos, Ms. Tripti Kadat, the medical officer in Shipra, as well as Ms. Lilaba, who joined as the cleaning staff from the hospital. Really wonderful to hear their voices in this meeting. So we thank you so much, our colleagues from India, for presenting and sharing with us your successes and the things that have gone really well. And I hope that you can stay with us as we continue this discussion and start answering more questions. So in the interest of time, just because we want to make sure we get to our final theme, I want to go ahead and move over to two other presenters who are part of our steering committee, Laxman Karau, Asia WASH advisor from Terra de Om, as well as Hadra Mukasa, WASH program manager from Amref Africa, Amref Health, who's going to cover for us budgeting for O&M. Again, you heard some of this in the overview. They're going to take a bit of a more in-depth discussion on this. So I'll pass it over. I believe Lindsay will go ahead and, Laxman is with us, but we're going to go ahead and do the presentation via video. So just give us 1 second.
Welcome to this presentation on costing for sustainable operation and maintenance of water services and healthcare facility. I'm from Terre des Hommes, based in Nepal. We are doing this costing for operation maintenance exercise under an advocacy project for sustainable operation maintenance of water services in healthcare facilities. The project is being carried out in Bardia district of Nepal under the Swiss Water and Sanitation Consortium program. The project aims to develop a water operation and maintenance policy for the healthcare facilities of a municipality. The facilities provide services like OPD and delivery services, and use the policy outline and the experiences acquired in the process to advocate for elements necessary for ensuring sustained operation and maintenance of water services in healthcare facilities in general. Budgeting based on systematic costing is one of the important elements here. Here I have shown two documents we referred and started with for the costing. The first is from IRC, the Netherlands. This covers costing for water services in general. The second one is for costing of healthcare facility water services. This is from UNC Water Institute. This document is available in wasinhealthcarefacility.org along with its costing spreadsheet. Yeah, these are the costing components that must be considered for ensuring sustained WAS services, also called life cycle costing. There are 6 elements here. The first is the initial capital expenditure. The second is costing for operation and maintenance, called OPEX. That also covers regular minor repair cost. The third is rehab and renewal cost. The fourth is cost of capital, such as interest on loans. And the fifth and the sixth cover direct and indirect support cost. Costs such as for monitoring, policy development, planning, capacity development, regulation, etc. The current practice here is doing costing properly only for the first component, the initial capital expenditure. The second, OPEX, that is related to operation maintenance, is one of the major elements in our project. OPEX covers cost of operation and minor repair needed for running the system on a regular basis. Here we are showing calculation of annual repair cost and functionality. Functionality is expressed as fraction or percent of the expected time the facilities are functional. In addition to the breakdown frequency is breakdowns in a year. Functionality is related to time needed to address the breakdown. And the yearly repair cost is related to the cost of each repair. And finally, this is a new element we are working on. While developing costing framework within operation and maintenance policy development, we realized the relevance of linking functionality with coverage and usage. What we have tried to do here. We hope this exercise will help us in developing more realistic policy in which the performance can be monitored and enhanced using coverage and usage along with functionality and the associated costs. We will share later the results and experiences, and we welcome any suggestions and remarks. We can also be contacted through this email address. Thank you.
Thank you. So that was Laxman Corral from Terra de Om, who actually is here in the webinar. But because we want to make sure we have time to share, we're going to go ahead and pass on to Hadra Mukasa from AMREF Health Africa, and she will continue this segment on budgeting for O&M. Go ahead, Hadra.
Thank you very much. I'll give experience of O&M of Washington Healthcare Facilities by Amuru District Local Government and AMREF. Next slide. Just like Jason presented the research, it's a similar thing in Uganda where O&M is not planned or budgeted for, but then at a national level, there are efforts that have been put in place. For instance, there has been allocation, there's a policy guideline to allocate 30% of primary healthcare budget to health promotion and disease prevention. Health promotion disease prevention means everything, including operation and maintenance, including health education, so 30% of the healthcare budget is supposed to cater for that. And the policy says up to 30%, which means up to 30% could mean 0% based on the priorities that the health facility in charge sees fit for the quarter. Also, another thing that government of Uganda has put in place is to make sure, like Jason said, when there's community involvement in operation and maintenance, government has put in place what we call the Health Unit Management Committee. Previously, the cardinal role of this Health Unit Management Committee was to oversee budget expenses at the healthcare facility, handling of medicines and drug supplies. But then they didn't have so much interest in the operation and maintenance of Washington healthcare facilities. However, this has become a key window of increasing operation and maintenance in healthcare facilities. And then, like Jason said, the result-based financing, which is a new thing that is a new kid on the block, is another national opportunity for operation and maintenance of Washington healthcare facilities. Next. So in Amuru district, there has been deliberate effort for operation of WASH in healthcare facilities. Now, the deliberate effort comes in when the personnel in charge is not the only one that is in charge of operation and maintenance of Washington healthcare facilities. When the responsibility and when everyone gets when it's everyone's responsibility, especially the healthcare facility in charge, then there's deliberate effort. We've also seen that when the community holds the healthcare facilities accountable, gone are the days when the communities would just go and accept to have a very dirty toilet. But when communities are empowered to hold the healthcare facility in charge accountable, then there's deliberate effort to have operation and maintenance plans in place. And also there is the personnel that is in charge of health operation and maintenance, the health assistant or health inspector that is based at the healthcare facility, is in charge of making a budget and a plan. Because if you don't have a plan, then it won't be, there is no budget for it. And so when the healthcare facility in charge and the health assistant have their budget and plan, those have an opportunity to present this during the sub-county budget conferences. We've also, together with the district, oriented the Health Unit Management Committee to monitor and enforce O&M. Not like before where they would only come and take stock of drugs and see how drugs are being utilized or money is being spent. Now it's their responsibility to hold the healthcare facility in charge accountable for the state of WASH in healthcare facilities. And in so doing, when community dialogues are held, even the communities have a voice to ask for accountability. Then also, we have advocated for enforcement of the 30%. Like I said, up to 30% could mean 0%. But then we've empowered the Health Unit Management Committee and also the sub-county authority to push for allocation of money as requested for in the plan of operation and maintenance by the health assistant. It may not be 100%, but at least with a plan in place, we see it work, that money is allocated there. And also having infection prevention and control contribute up to 30% in result-based financing, pushing that it has a bigger weight, because then that means if I don't pay attention to operation and maintenance, when it comes to scoring me for the result-based financing, I'll underperform, and that makes it my responsibility as a healthcare facility in charge. Next. And so one of the key outcomes we've seen is with the district, we installed water systems in 6 healthcare facilities. And these are solar-powered water systems that are supposed to make sure there's running water. Like in the past, it would not be uncommon to find a system that was installed breaking down, especially 2 years after the project has closed. But now, because infection prevention and control contribute to the weight of result-based financing, because now WASH becomes a key drive to get more funding, these systems have been well taken care of. The Health Unit Management Committee is in constant touch with the Hand Pump Mechanics Association. They are able to raise funds from the sub-county to pay for preventive maintenance. And so the drive therefore becomes a responsibility of the healthcare facility and comes from within, as opposed to waiting for the district health officer to come and do supportive supervision. Then people remember that O&M of WASH. Then also, because there's a price attached to operation and maintenance, there are innovations to maintain functionality of these healthcare facilities. Because if you converse that with the result-based financing and IPC, the coded bins and having clean water, running water. So this water facility running contributes to whatever results come out of your performance under result-based financing. And also healthcare facilities have been able to monitor and repair. So using the M&E funds, because initially we have to wait. There was this common talk of there was no money. It wasn't uncommon to find a broken tap of $25,000, less than $10, and the excuse is there was no money. But now people have started thinking outside the box. Like if we want to really have water running, then we have to think outside the box, either ask the sub-county or ask a prominent person in the community to help us purge in the pace. Then also, because there is improved quality, this has contributed to the bigger result-based financing picture. Because the result-based financing is not all about IPC, but also uptake of services. So there is increase in uptake of maternal newborn child health care services due to the improved WASH systems in these healthcare facilities. So making WASH a key pivot to performance that is tagged to funding will ultimately result into the duty bearers paying attention to the functionality and operation of this WASH in healthcare facility systems. Next. Yeah, like I've been alluding to, this is not just going to happen. There has to be drivers, there has to be ingredients to make this happen. Efforts are more deliberate. We've seen in these 6 healthcare facilities, and the district is now working on the 7th. Efforts will become more deliberate when WASH is part of the felt need of the health workers, as opposed to knowing that my role is to treat, have all these people seen out of my catchment area, but knowing that seeing people and having a broken water system, and then the monitoring team comes and finding there's no water, or finding will result to me not scoring high, and so not having all the money that I should have got, makes it a shared responsibility, actually makes it top on agenda because it's a key contributor to all the other aspects. Then also WASH systems that are appealing and make work easier for the health workers are most likely going to be catered for. We've seen this, where health workers have to carry hand washing facilities every morning, bring them out, fill them with water, carry this. It's not uncommon to find these hand washing facilities empty. But where you've put a hand washing facility like pedestrian operated, knee operated, where they are peeling, they're taken care of. So this goes back to thinking about operation and maintenance right at the point of designing the system. If you give me a bad design, I will not love it, and the chances of me not taking care of this system are going to be so high. And then also governance has played a big role in this, in making sure there's a plan, there's budget, and also funds allocated. When the health unit management committee, which is part of community and not part of the health workers, are given an oversight authority over the WASH systems, then the healthcare facility team become more accountable. And then when accountability is enhanced, we've seen you'll find these systems working, you'll find deliberate budget allocation. Then the health unit management in charge is actually going to demand for the plan from the health assistant, as opposed to waiting for the health assistant to not bring a plan and then maybe say, oh, you didn't give me your plan, so there's no budget. So the accountability then becomes a two-way system. And I think that's it from me. Next. Yeah, I thank you for listening.
Great. Thank you so much, Hadra. Really great presentations from both Laxman and Hadra. And just because I see there's some activity in the chat, I think there's a question here. It specifically looks like to Hadra about community involvement. And so one of the questions is, it would be great to hear more about how community involvement in accountability is working. Is it just through the HUMC, or are there other mechanisms? And do you have any tips for others trying to develop similar community engagement? So I'll pass that to you, Hadra.
Yeah, thank you very much. So in addition to the Health Unit Management Committee, we do what we call community dialogues with the healthcare team. So what happens is once in a month, the health unit team, together with representatives from communities led by the Health Unit Management Committee, have a dialogue. It goes beyond just washing healthcare facilities and also caters for things like customer care, caters for things like what community feels about the health workers, and also caters about what the health workers expect from the community, especially when it comes to the utilization of the WASH services in the healthcare facility. So it's not just Health Unit Management Committee. In as much as the Health Unit Management Committee interfaces with the health unit team regularly, community also has a chance to interface through their representatives with the health unit team.
Great, thank you, Hadra. So I am so very grateful for all of our speakers that we've had. We've actually come to our last set of speakers. And so what I want to do is, before we close up, pass over to Lindsay, who is going to go over some resources that we have for you and talk about some opportunities that we have for other case studies. So over to you, Lindsay.
Great. This will just take a second. So I just want to recognize, thank you to Dan Campbell from UNC, who pulled together what he could find on resources on an O&M. And Haley dropped it in the chat. She can drop it in again. Sections on guidelines, toolkits, and researches related to O&M and Washington healthcare facilities. Big note, it's 1 page long. There's not many resources that talk about this. So if you are in the process of doing this work, highly encourage you to document it. That doesn't have to be a formal research paper. It could be a short case study you publish and then you put on the WashingtonHCF.org website. But I think from all the conversations we've had today, there's still a lot of lessons to be learned, experiences to be shared. And we know that every time it comes up, O&M is critical for sustainability, yet there isn't much conversation about what that actually looks like. So in kind of pulling this all together, I do have one final video from Guatemala. So let's go full circle. Engineers Without Borders was kind enough to get us a short video that sort of puts all these different pieces into one place. So I'll go ahead and play this final video before we close.
Today we have a tank that is raised and it has about 1,500 gallons. And we have a new pit that we did. And the hospital has water supply. And on the 4th level, we have good pressure of water, which is very good for all of the hospital staff and patients. The maintenance with this new system, as far as we can reach and observe, is measuring the wattage, the voltage in the control systems of the pit so that we can have an idea of how the pump is working, the pump that's inside of the pit. Now, in terms of the chlorination dosage, we check it constantly to see that it's not clogged or the discharge is not clogged by the sodium chloride.
That was wonderful. Thank you so much, Rotary Engineers Without Borders, supported by Rotary, for this great project summarizing it. Joanne, I'll hand back to you.
Great, and that was actually a great way to come to a close here. So this is the end of the presentation section of the webinar. We're going to now transition to small group discussion. I will again thank all of our wonderful presenters and discussants who have shared with us such great in-depth information, those from our steering committee, colleagues that were joining us, Steve Crow from Engineers Without Borders, as well as our colleagues from India. But thank you all, and as well as those who are coming in through video. So just even this last video, all of the hands who have pulled together to make this session just so truly informative and impactful. So we thank all of you. And so for those who need to log off, please go ahead. We've come to the end of the presentation. But if you do want to stay, we're going to have about 15 minutes or so of discussion and transition ourselves into breakout rooms where we'll be able to, again, spend some time on the 3 different themes that we presented today, whether that is personnel, budgeting, or the planning component. And so if those of you would like to stay, please go ahead and do that. I think we have a poll here we want to quickly run just so we can understand how many people want to have discussions in which room. So if you would just go ahead and look at the poll that just popped up and respond for us, which breakout room would you like to join? And then if you'll be participating in another language other than English, please go ahead and complete that section, just so I'd like to let you know that we will have rooms for Spanish and French speakers if you decide to stay with us. But for those of you who are signing off, thank you so much. Lovely to have you here. We will be back in June. Please go ahead and send us some ideas or thoughts for what our topic will be as we're continuing to plan and create what we'll be doing in June. But again, just take another 30 seconds for those who are staying with us. Let us know where you'd like to be placed in terms of your breakout room, and then we will begin the discussion in about 2 more minutes. Thanks, everyone.
Thank you so much to everyone. Thank you.
Thank you.
If we could just answer the quiz here, this just helps me know, you're gonna be able to choose your room. It just helps me know how many rooms we need. There's still 60 some of you on, and if you all wanted to be in the same room, it might make for a less enjoyable breakout room. So just take a second here. I will.
4 more seconds.
Recording as well.